First of all, I would like to thank our respected Girish Gupta sir for giving me this opportunity to present a clinical case in our first collaborative meet with SGPGI. I'm going to present a case under his esteemed guidance, who is our HOD and professor, and the DM neonatologist, Dr. Chinmay Chetan sir, presenting a case of a 32-week early preterm baby with weight of 2,280 gram, low birth weight, appropriate for gestational age, male, lower segment cesarean section with respiratory distress syndrome, with bilateral pneumothorax, with right-sided collapse consolidation, with neonatal jaundice and anemia. Mother antenatal history and obstetric history has been uneventful. She had a leaking PV for 2 days, for which she received antibiotics. She delivered through lower segment cesarean section for fetal distress with previous LSCS at 32 weeks of gestation. Placental details are not known, and antenatal steroids and MGSO4 not covered. Baby cried immediately after birth and presented to us at 10 hours of life with complaints of respiratory distress since birth. Baby has received a CPAP and IV fluids outside, but not received surfactant, and in view of persistent respiratory distress, referred to us. We don't have X-ray film right now, but that time it was suggestive of chest expansion was present up to 7th rib with visible air bronchogram. At presentation in emergency, newborn was hypothermic with temperature of 35 degrees Celsius, pink in color, with respiratory rate of 68 per minute, saturation 97% with oxygen by hood and 88% at room air, with CFT of less than 2 seconds, heart rate 124 per minute, mean blood pressure 41 millimeter of mercury, with PiO 1.8 with sugar, normal sugar. Anthropometric parameters were appropriate for gestation age. Chest was barrel-shaped with tachypnea, subcostal intercostal retractions present bilateral lower zone, with grunting was audible, but bilateral ear entry equal. So Downey's score 5/10. Rest systemic examination was normal. At presentation, ABG was suggestive of metabolic acidosis with compensation with hypoxemia with all these parameters. Chest X-ray was suggestive of expansion up to 7th rib was there with fine reticulogranular opacities with visible air bronchograms. So suggestive of respiratory distress syndrome. So we managed this case with bubble CPAP started at 5 centimeter of water with FiO2 of 40%. In next 2 hours, distress improved, retractions decreased. At 48 hours of life, there was worsening of distress in form of increased intercostal retractions and saturation was 91%, but bilateral air entry was equal. So we increased CPAP from 5 to 6 centimeter of water with FiO2 41%. Then at 58 hours of life, there was worsening of distress in form of increased retractions with saturation 90%. So we increased CPAP to 7 centimeter of water with FiO2 from 40 to 45%. Then in next 1 hour, there were episodes of desaturation with worsening distress, but bilaterally air entry reduced and transillumination test was negative. ABG was suggestive of metabolic acidosis with respiratory alkalosis with these parameters and lactate of 2.1. So we intubated and put on SIMD volume guarantee mode. Clinical impression was a pneumothorax, so we immediately did needle decompression. Simultaneously confirmed our findings with chest X-ray that was suggestive of bilateral pneumothorax. Immediately bilateral intercostal tube drainage has been done and minimal fluid, pleural fluid drained out from right side. Pneumothorax drained out, vitals improved. Since we had first time experience of putting ICD in our department ourselves, so it is malpositioned bilaterally, so ICD has been repositioned at 62 hours of life. By day 4 of life, distress was improved. Trial of non-invasive ventilation was given with following settings. Then at day 6 of life, right-sided ICD accidentally pulled out. So X-ray was suggestive of right-sided collapse consolidation as there is a mediastinal shift towards right side, compensatory hyperinflation on the left side with low volume of lungs. On left side, chest expansion was adequate. Pneumothorax has resolved, but there was a minimal drain output was present, so ICD is kept in C2. Then next day, day 7 of life, baby had again respiratory distress. For X-ray was suggestive of recurrence of pneumothorax on right side. ICD insertion again has been done on the right side and pneumothorax drained out. Again, ICD were malpositioned, so we manipulated our ICD. In view of bilateral pneumothorax in a preterm baby with recurrence of pneumothorax, we kept a suspicion of congenital malformations. So we went for CT thorax at day 8 of life. It was suggestive of left-sided small consolidation with pneumothorax. And on the right side, there is a collapse was present as suggested by shifting of the main bronchus on the right side with small area of right-sided pneumothorax. This is an axial view lung window suggestive of the same findings. So CT thorax was suggestive of right-sided collapse consolidation, left-sided small areas of atelectasis with bilateral small pneumothorax and bilateral ICD in situ. At the 8 of life, right-sided ICD has been clamped for 24 hours as air column was not moving. There was no worsening of distress, so right-sided ICD removed on day 9 of life. Followed by left-sided ICD there was no drain output for 48 hours. Air column was not moving. It has been clamped. There was no worsening of distress. So left-sided ICD removed on day 13 of life. Then we go through an X-ray 6 hours post ICD removal to check for any reaccumulation on day 13 of life. This X-ray suggesting of right-sided expansion is there. Pneumothorax has been drained out, but low volume lungs, and there is a mediastinal shift towards the right side. Compensatory hyperinflation on the left side. Right-sided inhomogeneous opacity is present with right side cardiac middle silhouette is there, and diaphragmatic border is also being obscured, which is suggestive of right-sided collapse consolidation. So we attributed this collapse consolidation due to absorption atelectasis, as there were a lot of secretions were present. So it might be due to mucus plug, because if it would have been because of pneumothorax, there would have been compression atelectasis. For pneumothorax, there has already been drained through ICD insertion. For this absorption atelectasis, we adopted this modality, gentle chest physiotherapy, which has proved to be a mainstay of treatment in this case. And pain management has been progressive at all stages. So chest physiotherapy, humidification and warmed oxygen has been given. And for humidification, nebulization with normal saline and N-acetylcysteine has been given to break down these mucus plugs. We can also customize our approach by giving bronchodilator nebulization to dilate the bronchus before giving NAC, followed by postural drainage done as there was right-sided collapse. So baby is being nursed in left lateral position, followed by percussion and vibrational chest physiotherapy. And if there were secretions, the suction has been done on SOS basis under aseptic precautions. Post-chest physiotherapy, there has been marked clinical improvement in our case as tachypnea settled, retractions disappeared, right-sided air entry improved. Saturation also starts improving on minimal support with triple HFNC, which has been given for 3 days, then at room air. There was better drainage of secretions, activity improved. We could not get chest X-ray done as there was a clinical improvement and already a lot of radiation exposure has occurred. Supportive therapy has been continued in form of nutritional support being given with adequate proteins and calories, vitamin A, vitamin D, zinc, calcium, phosphorus, omega-3 fatty acids, and various micronutrients, selenium, manganese, and magnesium. Along with that, KMC, chest physiotherapy and oil massaging has been continued with nebulizations. PRPC support has been given with anti-reflux measurements and early stimulation. All lab parameters, they were not suggestive of any sepsis. They were within normal limits. COVID serology of the baby was negative. Septic screen has been repeated twice, which is being proved to be negative, sterile. Pleural fluid analysis was done, that was clear, yellow in color. Cells were 50, 100% monocytes, but we lost our sample, so we could not get protein done. Culture and sensitivity was sterile. So summarizing my case with during hospital stay, baby has been since birth on bubble CPAP with escalating pressures of 5, 6, and 7 centimeter of water. Then on mechanical ventilation from day 2 to day 4. Non-invasive ventilation from day 4 to day 14, then on triple HFNC from day 15 to day 18, then maintained at room air from day 19 till discharge. Developed pneumothorax at 60 hours of life, for which needle decompression followed by bilateral ICD insertion has been done. At day 6, right-sided ICD has been pulled out, and there was recurrence of pneumothorax by day 7, so right-sided ICD reinserted. By day 9, right-sided ICD removed, and by day 13, left-sided ICD removed. Baby has been discharged at a corrected gestational age of 35 weeks at day 22 of life. All the anthropometric parameters were within normal centile, but weight was at 10 centile. So at the time of discharge, ROP screening, ultrasound, cranium, and hearing evaluation with Vera has been done, which was normal. Metabolic bone disease has been screened, so all the biochemical parameters were normal, and discharged on calcium, phosphorus, and vitamin D supplements with advice to follow up. For anemia of prematurity, assessment to be done at 4 to 6 weeks of age and discharge on iron therapy with advice of neurodevelopmental assessment at each visit. Routine vaccinations have been advised. Along with that, pneumococcal and influenza vaccine have been emphasized. So impression of our cases was that there was a risk factor of prematurity with RDS. We received CPAP followed by positive pressure ventilation and not received surfactant to improve compliance of lung. In view of bilateral pneumothorax, we suspected congenital malformation as it was recurrent and bilateral. So we went through CT scan and ruled it out. No infectious etiology was found. ICD has been manipulated a number of times, so we need to have a skill training in this. Ultrasound thorax could have proved to be a better modality in early diagnosis of pneumothorax. Earlier, we did not have ultrasound in our unit, but now we are having ultrasound in our unit. And for absorption collapse, chest physiotherapy has proved to be the better modality in management. Just a finding of an ultrasound pneumothorax, we get a lung point here, and there will be an absence of a lung sliding sign. For thoracocentesis should be done at second intercostal space in the mid-clavicular line. For chest tube drainage, safe zone for tube thoracostomy should be kept in mind. Various types of chest tubes we can use in our neonates with pneumothorax. We can use angled chest tube, straight chest tube, Malicot catheters, and assembled trocar chest tube. And we can use pigtail catheter. Sizes for less than 1500 gram baby, 5 French. For more than 1500 gram baby, 6 French. With the use of 18 gauge green color cannula or needle, we insert the pigtail catheter until this curved part is inside the chest. Prefer the tapered tip chest tubes. Trocar chest tubes to be avoided in view of various side effects like perforation, hemothorax, scar, or laceration of vessels and structures. We can also use ET tubes, and in emergency cases, we can use feeding tubes also of 10 to 12. Malicot catheter size is 10 to 12 inch. In last 2021, this year, we had a total number of cases with bilateral pneumothorax 5, and for unilateral pneumothorax drained out were 4 cases. That unilateral were, most of them were surgical cases post-operatively for tracheoesophageal fistula. We had an experience of pneumothorax drainage with Malicot catheter and with this ET tube. In one case, we inserted ET tube bilaterally. There's a Malicot catheter. And in this case, we inserted bilateral ICD only of 8, 10, or 12 inch. Risk factor for air leak in neonates, it can be because of elevated transpulmonary pressure. It can be because of pulmonary disease and positive pressure ventilation when there's a poor lung compliance, or direct trauma to airways. This is of most common types are pneumothorax and pulmonary interstitial emphysema. Ventilatory strategy in air leak is very important to know. We should always prefer volume guarantee mode if we are giving conventional ventilation. Reduce mean airway pressure by any of its components by modulating PIP, tidal volume, PI or P. Increase FiO2 to improve oxygenation. We can prefer increased respiratory rate up to 60 per minute, and low TI should be kept. High frequency ventilation is an important alternative strategy, keeping PEEP at low levels of 4 to 6 centimeters of water. MAP should be initially same as we kept for conventional ventilation, and frequencies like 15 Hz. For weaning process, decrease MAP progressively, tolerating high FiO2. So our learning point in this case that we should be very vigilant in monitoring of bubble CPAP with all the vitals in clinical examination on day-to-day basis. We should avoid bag and mask ventilation as far as possible, and TP's resuscitator can act as a good alternative. Non-invasive ventilation is definitely a better modality for respiratory support. ICD insertion should be done under a skilled person and it should be a part of any training. Nutritional support should be focus of therapy since beginning of our case management. Surfactant should be considered in this case, and chest physiotherapy has proved to be a good modality in treating absorption atelectasis in this case, and pain management has been emphasized at all stages. This is the master window slide for respiratory support from our respected Girish Gupta sir. Whenever we are managing any respiratory case, we should keep in mind started from our brain, which is the main respiratory drive for our body, from the bronchioles, from the nares or nostrils till the bronchioles. So humidification is very important. Maintaining the cilia function and epithelial integrity is very important. Then at the level of an alveoli gap for the gas exchange, ventilation perfusion should be kept in mind. And for the perfusion, we should correct shock or if any heart disease is there. Then to improve the oxygen content, as we all know, this is being carried by the hemoglobin. So anemia should be corrected. And then keep in mind at the cellular level, the mitochondrial dysfunction is there. So lactate should be kept in mind to increase tissue perfusion. So please keep all these things in the mind to manage any respiratory support. With this, I will like to end my presentation. Thank you all.